Good morning, everybody. I welcome you all to this panel discussion on other specific types of diabetes. While most of the diabetes can be classified as either type 1 or type 2 diabetes, they are less commonly seen other specific type of diabetes too. In ADA classification, they have all been clustered under the umbrella term other specific diabetes, and this include Moody and neonatal diabetes too. Though these are rare causes of diabetes, they are increasingly being recognized these days due to heightened awareness among the clinician and increasing availability and affordability of genetic testing. Establishing a diagnosis of one of these is important because this can lead to treatment modification as seen in Moody or neonatal diabetes, or the treatment can be directed to underlying etiology like in acromegaly and Cushing's, leading to better glycemic control. Also, establishing a diagnosis leads to prediction of the future course of disease, thus anticipating and screening for associated manifestation, leading to overall better management of these cases. When we compare these diabetes with type 1, these are usually monogenic and autoimmune antibodies are negative in these. Many of these are associated with atypical features like deafness, optic atrophy, or have multisystemic involvement. Some may have a history of exposure to drugs, and in their treatment, many do need insulin, but there may be a role of OHAs in it. And the key message is that we need to control the underlying cause, which is leading to this diabetes, that leads to overall improvement in glycemic control in these patients. So we'll be presenting various case scenarios to highlight some of these atypical diabetes. So in first case, a 2-year-old boy came to us with history of diagnosis of diabetes at 11 months of age. He had diabetic ketoacidosis at presentation, and he also had severe anemia requiring blood transfusion. At that time, that anemia was attributed to poor nutrition. His HbA1c at presentation was 17.4% and his antibodies were negative. He was discharged on basal bolus regimen of insulin and iron folic acid supplementation. Subsequently, he had an irregular follow-up and had poor glycemic control. He had speech delay and hearing impairment. His family history was significant in the form of he was a product of second degree contiguous marriage, and his elder brother had diabetes with onset in infancy and who was on insulin therapy. On examination, his anthropometry showed weight and height of less than third centile. He had pallor with no lymphadenopathy or organomegaly, and he had hearing deficit on CNS examination. So I would like to invite Dr. Meena Mohan for her comments. Like Dr. Meena, should we consider any alternative diagnosis at this point of time in this child?
Thank you, Dr. Sujit. Yes, of course, we should consider an alternative diagnosis because of the fact that diabetes was diagnosed here less than 12 months of age, and especially if it is less than 6 months, it is more strongly towards neonatal diabetes. Also, associated features like hearing deficit, eye involvement, anemia, and neurological involvement also allows us to consider a different etiology. Neonatal diabetes in another sibling or another family member, and low, very minimal or no insulin requirement soon after the diagnosis or even much beyond the partial remission phase also points towards other diagnosis. And here in our index case, we have age of onset less than a year of age. There is deafness, there is strong family history of consanguinity. There is also an older sibling that is affected, and antibodies are negative here. So we would definitely consider other concurring diagnosis here. Thank you.
Thank you, Dr. Meena. As rightly highlighted by Dr. Meena, there are many typical features in this case. So I would like to invite Dr. Amarnath to discuss the differential diagnosis of this case.
Hi, good afternoon all. So I would like to thank the PDU organizers. So here the atypical thing in this case was deafness. So deafness can be associated with various types of atypical diabetes. Most commonly it could be due to either Wolfram syndrome, mitochondrial diabetes, or thiamine responsive megaloblastic anemia. In Wolfram syndrome, there is a diabetes mellitus, diabetes insipidus, optic atrophy, and deafness. In mitochondrial diabetes, there is multisystemic involvement, that is neurological, muscular, ophthalmological, respiratory symptoms, and also uh, deafness. Typically diagnosed after 30 years, but it can present below 30 years also. In our case, there is a predominantly anemia, that is megaloblastic it could be, and diabetes associated with sensorineural hearing loss and involvement of other sibling. All these features I would like to suspect thiamine responsive megaloblastic anemia or Roger syndrome, as here the onset is in between the infancy and adolescence. Over to Suchit.
Thank you, Dr. Amarnath. With these differential diagnoses in mind, we went ahead and investigated this child. He had macrocytic anemia with parasuggestive bilateral sensory neural hearing loss. So, as discussed with by Dr. Amarnath, with this triad of megaloblastic anemia, diabetes, and hearing loss, we considered the diagnosis of strongly considered the diagnosis of TRMA and went with ahead with genetic testing. And the genetic testing showed a pathogenic mutation in the causative gene, establishing the diagnosis of TRM in our child. So, Dr. Ashima, would you like to elaborate the clinical spectrum of this TRMA, that is Rogers syndrome?
Yeah, thank you, Dr. Suchit. So this is a rare autosomal recessive disorder, and as was seen in the index case, where there was history of second-degree consanguinity with affected elder sibling, usually presents with a triad of diabetes mellitus, megaloblastic anemia, and sensory neural hearing loss. Anemia is usually the hallmark, which usually starts concurrent with the age of onset of hyperglycemia and is early in the disease onset. It is the anemia is megaloblastic. Diabetes mellitus can again appear anytime from infancy till adolescence. Progressive sensory neural hearing loss is generally seen early, but might also present little at the later stage. In a subset of these children, few of these may have optic atrophy, cardiovascular abnormalities, neurological deficits, and short stature. Next slide, please. So most of these children, the treatment remains treatment of the underlying problem, which is treatment with thiamine, usually in the doses of 25 to 100 mg per day. The anemia or the cytopenias would usually recover completely, even though the erythrocytes might remain macrocytic in appearance. If we look at the response to diabetes mellitus, treatment with thiamine would delay the onset of diabetes in few, with significant reduction in insulin requirement, and very few, a handful of few may remit. However, there would be deterioration in the glycemic control with the onset of puberty, etc., in which they would most of these would end up requiring insulin therapy. And sensory neural hearing loss, however, once it has been detected, it cannot be prevented and would require some treatment. Thank you.
Okay, thank you, Dr. Ashima. So, as suggested by you, we started this child on oral thiamine 100 mg per day and with optimization of insulin therapy, and he responded well to the treatment. His HP improved with 6 weeks of therapy, and his glycemic control also improved with the decrease in his total insulin requirement. Also, we went ahead with the family screening. The elder sibling also had the same disease. He had microcytic anemia, which was not picked up previously, and his genetic analysis showed the same mutation. The elder sister was normal. So in this case, we highlighted how anemia and hearing deficit led to the diagnosis of a rare cause of diabetes, that is TRMA. Now over to Dr. Ashima for the second case.
Yeah, thank you. So this was a 16-year-old boy who was diagnosed as beta thalassemia at 5 months of age, and since then had been on regular blood transfusions and iron chelation. Initially, the requirement of transfusion was 4 weekly, but gradually, currently, it had come down to almost 2 weekly requirements. He had associated issues of delayed puberty for which he was on hormone replacement therapy. He was short with a height SGS of minus 3.2 and was recently detected to have high fasting blood glucose. Next slide, please. So he weighed 43 kgs at 16 years with a height of 143 centimeters and a BMI of 19.2. He maintained a pre-transfusion hemoglobin of around 9.6. A fasting plasma glucose was 153, which was raised, and again a 2-hour OGTT value was 187, which was also deranged. Serum ferritins were high at 2,800 almost, and serum insulin was 5.7. So at this point of time, Dr. Amarnath, may I invite your comments for investigations and further diagnosis of diabetes in this case?
Thank you, Ashima. I work with Thalassemia Sickle Cell Society. So we see diabetes in second and third decade of life in thalassemia children, especially who have got very poor control, that is high ferritin level and less compliance. So coming to the iron deposition, simultaneously it happens in multiple organs, here mainly in the pancreas. Initially there will be insulin resistance followed by insulin deficiency. So along with this there is a hepatic dysfunction. So first there is a beta cell oxidative stress leading to beta cell apoptosis, then insulin deficiency. Prevalence of diabetes mellitus and pre-diabetes varies from 10.5 to 24%. Symptomatic glycosuria is very common, and diabetic ketoacidosis is very rare. Next slide. Coming to the lab investigation, we are supposed to start uh, investigating from 5 years of age, that is fasting plasma glucose, and according to ICETA guidelines, annual OGTT for all patients with thalassemia major aged above 10 years should be done. Now I would like to ask Dr. Meena what further investigations can be done.
Thank you, Dr. Ramannath, for that. So we always know that CGMS is always superior to OGTT alone in picking up any sort of diabetes, leave alone diabetes in thalassemia. So in this little study, it was very nicely demonstrated that in 16 children, OGTT was able to pick up only 5, whereas CGMS was able to pick up more than 2 times of normal, that is 12 children in this cohort. Also, HbA1c, which is usually done to find out glycemic control in type 1 children, cannot be made use of here because the half-life of RBC is very much less because of the hemolytic condition and also because of recurrent blood transfusions. Most likely, it is going to be the donor blood rather than the recipient's blood. So in this case, we have fructosamine, which is a product of glucose and protein, which also is known to have a short lifespan. And this actually reflects blood glucose over the last 2 to 3 weeks rather than 120 days in case of normal children without thalassemia. So this is the tool that is being recommended for assessment of glycemic status in such children. And it is also known that we could do an MRI T2 weighted to look at the iron load in the pancreas, which correlates well with the iron load in the heart. Over to Dr. Suchit. Thank you.
Thank you, ma'am. Various risk factors have also been identified in large cohort studies for development of diabetes in these children, especially it is more commonly seen in male gender. Patients who have poor compliance or inadequate dosage of chelation do develop diabetes early. There is also a correlation with increased liver iron concentration. Children who have coexisting hepatitis C infection or zinc deficiency develop diabetes early in comparison to those who are not affected with this infection. Coming to the management, for delaying the development of diabetes, one need to take care of the thalassemia well. They need to have regular blood transfusion every 2 to 5 weeks to keep pre-transfusion HB in the recommended range of 9.5, and their chelation should be started early as soon as 5 to 10 PRBCs are transfused or serum creatinine goes beyond 1000, so that the iron deposition in pancreas and liver is decreased and overall development and progression of diabetes is delayed. Once there is established diabetes, the main stay of treatment is insulin. Though people have also tried oral hypoglycemic agents like metformin, glibenclamide, and acarbose, but the experience with these are limited. There is some role of alternative medicine, but that needs to be established. Over to Dr. Ashima for further progression in this case.
Thank you. So this child was also advised strict compliance to chelation and was advised insulin to start with, which the patient had refused. So he continued with lifestyle modification, but ultimately at 18 years of age, he had to be started on insulin. This sums up my case. So over to Dr. Suchit for the next case.
Thank you, Ashima. Next case will be presented by Dr. Meena Mohan. Ma'am, can you go ahead?
Yeah, thank you very much, Dr. Sujit. So here we have a boy who has an elder sibling who presented with type 1 diabetes. And this boy was noted to have polyuria and also his urine was attracting ants. As mom knew that she was managing type 1 diabetes in the elder sibling, she had some sort of suspicion and did the blood sugar in the same glucometer and confirmed the diagnosis here. And as a toddler of around 4 to 5 months of age, he had blue bumps all over the body. At that point, he was heavily investigated and he was diagnosed to have hemophilia. So here is a mom who's challenged to manage two children under the age of 5 with type 1 diabetes and the youngest one having added hemophilia on top of diabetes. So we look at how he manifested for the last few clinic visits. So he was surrounded on basal bolus with Humalog and Lantus, and in January last year, he was known to have hematuria presenting during the last month, and his injection sites were lumpy due to the bleeding and hematoma, as one would anticipate. You can see the big bruise on his left shin over here. Next slide, please. So in April last year, he still had lots of values, high values, and bumpy sides because of the hemophilia. And he was advised Lantus to be given split to facilitate more absorption and also to decrease the volume in the way of decreasing his hemophilia or bleed inside. His hemoglobin A1C started slowly coming up. So in December last year, he continued to have lots of swelling and bruises, especially around his injection sites, and lots of high. His control of hemophilia was not brilliant in spite of having weekly factor VIII infusions as part of his hemophilia management. In July this year, you can see from this graph that he's got lots and lots of high blood sugar values on SNBG and lumpy sites almost everywhere, bruising on both sides, and mom started to even inject on the lateral abdominal wall, especially in the lump-free areas. And he's always been a thriving child, thriving around the 75th centile. So over to Dr. Suchit to look at a few more challenges in the management of this case, please. Thank you.
Thank you, Dr. Meena, for sharing this rare and interesting case of diabetes with hemophilia. There is scarcity of literature on this combination, and as seen in this case, like with subcutaneous injections, they are bruising and bumping, leading to irregular absorption of the insulin and poor diabetic control. So one can try prophylactic factors to avoid this bruising and bumping and thus better absorption and control of diabetes. Also, some precautions to prevent hematoma formation after subcutaneous injections can be taken, like using ice for 5 minutes prior to the injection and then subsequently pressing the site for 5 minutes. But even with these steps, it is a difficult disease, uh, like managing both diabetes and hemophilia. Also, we need to encourage physical activity in these children, as usually BMD is low in hemophilia, and with improved physical activity, there will be an improvement in BMD and glycemic control. So they can get involved in non-contact contact sports with proper protective equipment, but they need to avoid any high contact and collision sports. Also, if they have any target joints which are prone for bleeding, they can use braces or splints during the periods of activity. Over to Dr. Meena for further progression of this case.
Thank you, Dr. Sujit. We tried various other modes, even a trial of iPod, but it did not work because that was causing more pain because it was given at the same injection site. Mom also carried on trying in the flanks, thighs, or even calves in the subcutaneous areas wherever there was not much of muscle and wherever there were no bumps. And things got even more worse with post-COVID because there was very limited supply of factor VIII and the struggle continues. However, the lessons that learned or can be learned from this case are that life is too short to worry about and get bogged down by little things around. And there's always something positive to look out for all of us. And perseverance is the key. And never forget to smile. Like you can see the smile in all the whole family here. Thank you very much.
Thank you, Dr. Meena. Uh, Now I'll invite Dr. Amarnath for presentation of next two cases.
Thank you, Suchit. First case we saw TRMA, and second case we saw thalassemia associated with diabetes, and in third case just now we saw the hemophilia associated diabetes. Now we'll come to an interesting case where both the siblings are involved. First, coming to the younger sibling, that is sibling B. At the age of 11 years, she was presented to us with polyuria, polydipsia, polyphagia, and weight loss for last 20 days without any nausea, vomiting, or abdominal pain. The here presentation of diabetes was without ketosis or acidosis. There is a past history of operation of pseudopancreatic cyst at the age of 3 years, which is proven by histopathology. After that, she was started on basal bolus regime and sugars were well controlled without much fluctuations in levels. She was put on the basal bolus. Initial requirement was 2 units per kg per day during the first week. Then within 3 weeks, she is maintaining on 1 unit per kg per day insulin. So within 3 months, she gained weight from 35 to 45 kg, that is 10 kgs, and she is doing well and attained signs of puberty, and sugars are under good control. Next slide. So here, coming to the elder sibling, we are able to see the pancreatic duct dilatation on ERCP. Here the elder sibling and younger sibling both are females, and there is a genetic test positive for SPINK1 gene mutation for both the siblings. And here before treatment and after treatment, she attained puberty and also good weight gain. Coming to CGMS, here we see less fluctuations except in the night. Next slide. So coming to the elder sibling history, she is 13 years female. She has pancreatic insufficiency, that is exocrine pancreatic insufficiency needing amylase and lipase supplementation, which is absent in our index case. Coming to the workup of endocrine pancreatic insufficiency is absent in elder sibling, which is present in younger sibling. C peptide levels were low normal, but HbA1c is normal. Insulin antibodies were negative in both the cases. Coming to the pancreatic involvement, in elder sibling, there were multiple calculi with main pancreatic duct dilatation and obstruction with calcification, needing stenting, which we have seen in ERCP finding. So coming to our index case, she had pseudopancreatic cyst at the age of 3 years, underwent cystectomy, now has fibrosis of pancreas with shrinkage. The interesting thing here is there is a there can be involvement of both insulin and glucagon deficiency varyingly. Next slide. Now I request Dr. Ashima to summarize this case.
Thank you, Dr. Amarnath. So, what we saw in this case was fibrocalcific pancreatic diabetes, not a very rare form of diabetes. We do occasionally see few patients with this, usually presenting with a triad of abdominal pain, pancreatic calculi, and diabetes mellitus. And initially, thought this was thought to be related to an overt protein calorie malnutrition state or with deficiency of certain micronutrients. But now, with increasing understanding of genetics, we now know that there are few HLA associations which have been identified and certain genetic mutations like the SPINK1 and the PRSS gene, which also has been implicated in few cases. So, in our index case, this mutation was found with a strong family history. Most of these children, the course is usually aggressive, and presence of pancreatic calculi, pancreatic ductal dilatation on radiology is usually the hallmark of diagnosing of FCPD. The diabetes is difficult to control. Mostly these children have higher HbA1cs and poor diabetic control. They but would rarely develop ketosis or acidosis. So as also seen in the diagram above, the predominant population of FCPD, usually the age of manifestation is in the second decade to up to 40 years of age, and most of them would be insulin requiring patients, but again ketosis resistant.
Dr. Ashma, should we do,
Thank you, Dr. Sachit.
Dr. Ashma, should we do an ultrasound in all adolescents with diabetes and abdominal pain so that we are able to pick up this entity?
So ultrasound is can be one of the simplest investigations that can be done in such adolescents, especially when they present with uh, um, features like abdominal pain. Initially, a subset was identified where they were lean, thin, but the recent studies from South India and also from SGPGI and from uh, Kashmir have shown that a proportion of these patients might have normal weight or need not be always cachexia. So this remains as a high possibility, and few of type 1 diabetes or patients who were unclassified initially in the presenting in the adolescent age would eventually on follow up be later might later be getting a diagnosis of something like an FCPD. So a good follow up and a good clinical history is actually required in this subset of case.
Okay.
Suchit, just I
Prakash.
Thank you.
wanted to highlight here. So mainly the atypical things here was there is no ketosis and no acidosis, and there was also maximum weight loss. All these things features suggest of atypical diabetes. So yes, I would agree with Suchit that we can go for ultrasound pancreas in such cases. Thank you.
Yeah.
And as also been reported in these case series from India, all 100% of patients might not have everything. But yes, the radiological investigations do remain the hallmark of diagnosing FCPD, and now we have genetics with which might help us increasingly in diagnosing those unclassified diabetes that we have.
Yes, I agree. Like
Thank you, Dr.
in the
Suchit.
presence of high HbA1c with no ketosis, one should think of an alternative diagnosis, and
Yes.
this can be one of those. Thank you, Dr. Ashwin and Dr. Amarnath. So, next case is going to be presented by Dr. Amarnath.
Thank you very much, Dr. Suchit. Before going to case, I would like to tell about this diabetes camp. I am running 3 free diabetes clinics. Here, this girl, though she is having diabetes with multisystemic involvement, she is receiving prize for chanting mantras and interesting songs. So coming to the case, this 18-year girl, known case of multisystemic involvement syndrome, presented with diabetes without any acidosis or ketosis. HbA1c was 14 and she was put on basal bolus regime, now doing well. Coming to the examination, she has got short stature and also growth retardation. Weight is 32.4 kg, height 134 centimeter, head circumference was normal, Tanner staging was stage 4. Family history, she was a non-consanguineous child, third in birth order, other 2 siblings are healthy. So she is on medications like carnitine, coenzyme Q, riboflavin, and benalgesic. She has also global developmental delay. Next slide, please. Yeah. Coming to past history and examination, on examination of nervous system, there is a global developmental delay, ataxia, tremors, and hypotonia. Heart, there is involvement of right bundle branch block with she is on now on pacemaker. So muscle, there is a myopathy and hypotonia. Muscle biopsy revealed red ragged fibers. So left side we are able to see normal muscle biopsy, and in right side we are able to see in case of mitochondrial myopathy, that is red ragged fibers. Involvement of pancreas, there is a diabetes, and there can be sensorineural hearing loss. In this case, there is a sensorineural hearing loss along with that external ophthalmoplegia and retinopathy. So we have to do fundoscopy in this case. There can be short stature, and typically diabetes have no ketosis and acidosis is rare. Now I would request Dr. Meena to summarize important points from this case learning.
So this is a case, by now we all know, that is a case of Kearns-Sayre syndrome, which has a classic triad of chronic progressive external ophthalmoplegia, heart block, and pigmentary retinopathy. And the onset is before 20 years of age, and absence of ketosis and acidosis may also point towards atypical diabetes. And complete examination, including screening for other systemic mitochondrial and other multisystemic involvement, should be done during follow-up and also during surveillance. And the best mode of management would be to involve all super specialties team for a joint multidisciplinary ongoing care. And the baseline here and for all other atypical diabetes conditions is to treat the underlying systemic condition thoroughly. Thank you.
Suchi, just I wanted to add about this case. as we have seen in the first slide, though she is having multiple systemic involvement, parent came to our diabetes camp and she received prize for involvement in sports and other things. So diabetes, with diabetes children can excel. So tender loving care is very very important, apart from your diet, exercise, insulin, and your sugar check, which is called 4 pillars of diabetes. So I say the most central brick for all diabetes is love, tender loving care, and they are like angel. Like I can say this child was angel and she was chanting mantra of Ganesha. So what I would say is they are like normal children. They can perform very well. The most important point what we saw in my two cases was multisystemic involvement, screening for other siblings, and treatment of the primary condition. That is important. Thank you.
I totally agree with you, Dr. Amarnath, that we all need tender loving care for betterment of our life. So in last 30-35 minutes, we have tried to highlight and sensitize the audiences to some of the atypical presentation of diabetes, in which we should suspect a secondary cause or a non-type 1, type 2 diabetes. So I would like to conclude with some take-home messages. Like, we need to have high index of suspicion if atypical features are present, as seen in our various case presentations. If there is any anemia or multisystemic involvement or hearing deficit, um, the clue to diagnosis is usually in history and examination. So it is important to take a detailed history, especially family history, as many of these are monogenic. To establishing the diagnosis, a genetic test is helpful, as it will lead to labeling of a definitive diagnosis, and also will be helpful in subsequent pregnancy, and genetic counseling can be offered. The key point in all these cases were, with the care of primary or underlying condition, the the control of diabetes became better. So no matter of insulin or no matter of monitoring will lead to better glycemic control in these, until and unless the primary or underlying condition is taken care of. I thank all the panelists for the nice discussion we had, and I thank all the listeners for their patience. And the panel is open for any questions and comments. Thank
Thank you
you.
very much, all of you.
Thank
Thank you.
you. Thank you.
You just to summarize in 4 points. First point, look for ketosis. Second point, look for acidosis. Third point, look for genetic involvement. Fourth one, systemic involvement. These four are very important clues to differentiate between typical and atypical diabetes. Thank you very much.
Thank you.
Thank you.